Welcome back. I'm Andrea. There's Orla. And thanks so much for joining us this afternoon. So I know we all have these nagging worries. Did I lock the door? Did I turn off the stove? My big one personally at home is, did I turn off my curling iron? I'm
Oh,
constantly,
goodness.
driving away and wondering, did I turn it off? Did I not?
Actually, Andrea, I remember you saying that to me every morning that we left the hotel room in LA.
A
Did
hun-
I turn off the curling
I
iron?
know. I know. Sometimes I even take a picture. But when are these worries signs of something more, like OCD or obsessive compulsive disorder? Let's ask an expert. We're joined now by clinical psychologist in Toronto, Dr Monique Bhatia. Welcome back to the show.
Great to be on with you both.
Yeah, thanks so much for joining us. So first of all, right off the bat, what exactly is obsessive compulsive disorder, or as most commonly known, OCD?
Yeah, so obsessive compulsive disorder, or OCD, is a type of anxiety disorder. And, there's two, components typically associated with OCD, as in the name, the obsession and the compulsion. Most people have both obsessions and compulsions. Sometimes it could be either. But essentially, you're looking at two different parts to OCD. The obsessions part is defined as kind of recurrent and persistent thoughts or images or urges that are obviously being experienced as very distressing and anxiety provoking, and they're always intrusive and unwanted. So you don't want to have these recurring thoughts and images or urges. And compulsions are repetitive behaviors, so they could be things like hand washing or ordering or checking behaviors, or mental acts like praying or counting or repeating words silently that people feel driven, almost compelled to do in response to these obsessional thoughts, images, or urges. And they also might, in some cases, have to be done in a very particular way to follow a rigid rule or organizational process. And secondly, the reason why people engage in these compulsions or mental acts, these behaviors or mental acts, is as a way in their mind to kind of prevent or reduce the anxiety associated with the obsessional worry or a feared event. But the real problem that comes from this is a lot of times there's no realistic connection between the compulsive behavior and the obsession it's trying to stop. So those are the two main functions, two main parts of OCD. You talked at the onset there about, some examples about, leaving the door unlocked or whatnot. The main thing here you have to understand when you are being diagnosed with obsessive compulsive disorder is these obsessions and obviously compulsions are time consuming. So as a psychologist, as a mental health professional, we're looking to understand, like, okay, how much time in your day are these obsessions and compulsions taking up? So it has to be at least, let's say an hour of your time per day, more, and it causes, this is the most important part, it causes, clinically significant impairment in your ability to function socially, occupationally, relationally. So, we all have these kind of passing, fleeting thoughts, oh, did I lock the door, or did I, take off the curling iron or whatever. But someone who has OCD, it's a destructive thought process. It takes up more time than not in their day, and it causes significant dysfunction in many parts of their life.
Dr. Bhatia, but where does it stem from? Like, how come person A continues their daily life with no issues to do with OCD, and person B has OCD, it's huge impact on their daily life? Is it in the genes? Is it from a bad experience in their childhood? Where does it stem from?
That's a really good question. I mean, the idea of like how, kind of what the etiology is, what we know is it's a variation of impacts. So it could be, some risk factors would be like you mentioned, there's the idea of, genetics. So, people have a predisposition to particular kind of, behaviors or dysfunctions. So there could be a, family history, a genetic composition. It could be also due to environmental factors. In your environment, that could be a trigger or a response to some sort of negative experience. It could be based on temperament, so your ability and how you react emotionally to situations. So there's no clear cut, this is how one person gets OCD and one person doesn't. It's typically we're looking at genetics plus environment as the kind of cluster that leads to someone to be diagnosed with OCD and to form it.
So how common is OCD?
Yeah, so the prevalence rates are about 1% of the population in Canada will be, diagnosed with with OCD. And it's interesting, there's differences among, sexes. So females are slightly more affected in adulthood with OCD, and males are more likely to be affected or diagnosed in childhood. So 25% of males are diagnosed before the age of 10. But the average onset, so the idea of like when the average person would be diagnosed with OCD is about 19 and a half years. And onset of OCD is quite unusual or rare after, let's say, 35 years old. If you're 35 years old and older, it's not impossible to be diagnosed with OCD, but it's more unlikely to happen if it already hasn't happened by that point.
You're listening to Now Trending. I'm Orla alongside Andrea, and we're chatting to clinical psychologist in Toronto, Dr Monique Bhatia. So guys, I was engaged years ago, and my fiance at the time, he developed OCD after his mother passed away, after a long battle with cancer. And all of a sudden, he couldn't fly, couldn't get on a chairlift to ski. Like our whole lifestyle just stopped. I lived on the 19th floor of an apartment building, and every single day he would say, I'll meet you in the garage to go to work. He would walk down all 19 flights of stairs. Wow. And then we got back at the end of the day, he would walk up 19 flights of stairs. Nevertheless, he lost a lot of weight, obviously. Clearly he loved me because he was walking up the 19 floors. But it was just incredible to see the switch around and how it affected a relationship when OCD sets in very deeply. So what are the different levels of severity when it comes to OCD for adults?
Yeah, it's a very good question. So, when you're looking at severity, it kind of ties back in the idea of like, so, to how time consuming, how all encompassing, the OCD can be. Like, there's some people who can't leave their homes because it's just the recurrent thought, or let's say fear of contamination is so strong, let's say, that they're just paralyzed. They avoid everything. Because that's a problem with that context. Like you try to avoid triggers, right? If you're afraid of contamination, you're not going to be in society, right?
Right.
So it really depends on the nature of the severity of how far this progresses into your life. But also there's an important part we look at is like, your level of insight, right? So for many people, they have really good insight, meaning they come to my office and say, I have OCD and it's unwanted, I don't want it. And I know, Dr. Bhatia, this is irrational. Like, I understand it's irrational.
Yeah.
I think where it becomes more problematic is where there's poor insight or even a belief, because, these are all dysfunctional kind of beliefs. They're not rational, right? Obviously.
Right.
I mean, it's not easy to, it doesn't make it any easier to get past, but someone who has poor insight who actually believes these to be kind of valid are more likely to have more ingrained and chronic levels of OCD. So severity is a function of like, am I able to, can I function? Can I still go to work? Can I still get out of bed? Can I still maintain my relationships? You mentioned your example earlier. I mean, those kind of situations can have a strain on relationships, right, at some point. So it depends. There's no kind of one-size-fits-all. You're really looking at impairment across different markers. And we always look at frequency, duration, intensity, and those are kind of the markers to get to the level of severity in terms of where we're at in a treatment process as well.
And I guess, if this is something that somebody thinks that they might be suffering with, the best thing to do is to reach out and to seek help.
Yes, absolutely. This is something you really can't do on your own. It's getting help is important. There's very strong empirical evidence for, cognitive behavioral therapy to treat OCD. So if you're out there listening and this is a challenge for you, you're not alone, and getting help. There's a lot of good research out there on the outcomes of evidence-based psychotherapies to treat OCD.
Well, Dr. Bhatia, thank you so much for the conversation and for your time today.
I appreciate it. Thanks for having me on.
That's Dr. Monique Bhatia, a clinical psychologist in Toronto. Coming